Welcome to Prescription for Justice. My name is Martin Donahue. Thank you for joining us. The United Nations Declaration of Human Rights, to which the United States is a signatory, states, "Everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, and medical care." While widely regarded for its scientific and technological advances, the U.S. healthcare system ranks 37th in the world, giving us the poorest health among all rich nations. We rank near the bottom among westernized nations in overall population health, life expectancy, infant and maternal mortality, and numerous other measures of health and well-being. Even so, our annual healthcare expenditures per capita are $10,348, or almost 18% of the gross domestic product, making us number one in healthcare spending. For comparison, Canada, Australia, Japan, and most European countries spend $3,000 to $6,000 annually per capita and achieve better outcomes. Before the passage of the Patient Protection and Affordable Care Act, otherwise known as ObamaCare, 42 million Americans lacked health insurance. Today, that number stands at 28 million, with 30 million more underinsured and many more remaining in dead-end jobs to keep their insurance or going without needed care or prescriptions due to inability to afford high costs. This leads to a shocking 29,000 deaths per year. High medical costs are the number one cause of bankruptcy in this country, and the majority of those bankrupted had coverage. In our country, health care is paid for by a complicated amalgam of federal, state, and local governments through Medicare, Medicaid, the VA or Veterans Administration, the Indian Health Service, and jail and prison systems, along with private insurance companies, patients themselves through out-of-pocket expenses, and charities. Some desperate patients turn to crowdfunding platforms or even volunteer as research subjects to pay for needed medical care. Healthcare outcomes are worse for ethnic minorities, the poor, women, rural populations, and the less educated. And insurance, which is primarily employer-based, is offered through about 800 companies, each with a complicated and ever-changing assortment of plans. However, just 2 companies control over 50% of the market in 45 states, and 5 companies control 83% of the total market. Premiums and deductibles have been increasing, and the health insurance industry earns large profit margins. The median annual compensation of healthcare CEOs, who are almost all men, is about $16 million, more than that of bankers. The industry, whose loyalty is to their shareholders, not to their patients, has paid out billions in fraud-related penalties over the last few decades and uses a variety of tactics to limit actual care, which it refers to as the medical loss ratio. There is large variability in charges by region, hospital, and insurance status. Often the uninsured are charged 2 to 3 times those with coverage. The health insurance industry has high administrative costs, running between 16 and 20%, versus just 2 to 3% for the government-run Medicare and Medicaid programs. Our administrative costs are $3,470 annually per capita versus $930 under Canada's single-payer system, which provides equal and in some cases superior outcomes. We spend $471 billion per year for billing and insurance-related costs alone. The average full-time physician spends nearly $100,000 per year to fulfill billing and insurance requirements. Administrative tasks, not including charting or patient phone calls, take up 17% of the average physician's work week. Meanwhile, U.S. drug costs are skyrocketing, accounting for over $500 billion annually. We spend twice the amount Europeans spend on the same drugs, and even more compared with other countries, perhaps explaining why some Americans cross into Mexico to get desperately needed prescriptions. Middlemen such as pharmacies, pharmacy benefit managers, and dispensing hospitals and clinics account for 1/3 of costs, but the industry is immensely profitable. Despite its reputation for innovation, 90% of new drugs are little or no better than pre-existing agents, designed to dig into another company's market share. The often quoted cost of developing new drugs of $1.3 billion based on myriad biased and unreal assumptions, has been superseded by more comprehensive economic analyses which put the cost at about $60 million or $186 million if failed drug candidate costs are included. Some companies have dramatically increased the cost of medications like insulin for diabetes and epinephrine for severe allergic reactions. New anti-cancer drugs typically cost more than $100,000 per year. The pharmaceutical industry, which spends more than twice as much on marketing as on research and development, is the biggest defrauder of the federal government, as determined by payments made for violations of the Federal False Claims Act. Meanwhile, the industry gives billions in gifts, speaking fees, and research grants to physicians, hospitals, patient advocacy groups, and politicians, all designed to maintain high prices and thus profitability. While spending on prevention and public health is life-saving, and usually cost-saving as well, less than 5% of the healthcare budget is devoted to these areas. Increased spending on social services and correction of the lopsided maldistribution of wealth in the U.S. through fair tax policies could dramatically improve health and longevity for everyone. However, our country, while number 1 in healthcare spending, is number 25 in social services spending. A 2009 study from the prestigious British Medical Journal found that 880,000 deaths per year in the U.S. would be averted if our country had a smaller income gap and stronger social safety net like most Western European nations. Furthermore, a 2007 study from the respected American Journal of Public Health noted that while medical advances averted a maximum of 178,000 deaths between 1996 and 2002, correcting disparities in education-associated mortality would have saved 1.3 million lives during the same period. Finally, an earlier 2004 analysis from the same journal reported that whereas medical advances averted 177,000 deaths between 1991 and 2000, equalizing the mortality rates of whites and African Americans would have averted more than 3.5 times as many, or 686,000 deaths. To summarize, our country has a fragmented, expensive healthcare system which does not provide adequate care to millions and is made worse by unfair tax policies and inadequate funding of social services, causing immense suffering and death. How did we get here? And how can we fix things? Our guest tonight is Dr. Samuel Metz, who will help us figure this all out. Dr. Metz is a physician in Portland, a member of Oregon Physicians for a National Health Program, and a founding member of Mad as Hell Doctors. His opinion pieces have appeared in the New York Times and many Oregon newspapers. Welcome, Sam. It's
Thank you
an
very
honor and a privilege to have you here, and I must say I've followed your work over the years and consider you somewhat of a mentor, so I'm very grateful that you've come on the show. Tell me, many people believe that we have the best healthcare system in the world. Is that not true?
You have given extraordinary documentation of why we're not. The people who say we have the best healthcare system in the world typically either lack any concept that we can do things any better, or have a vested interest in not doing anything. As you point out, Americans spend more on healthcare than any other country on the planet. Our medical outcomes in public health is the worst in the industrialized world. We're the only country that endures medical bankruptcy from people trying to pay for treatable diseases. We're the only country in which our employers pick our insurance company, pick our physicians, pick our benefits. Consequently, we're the only country that has labor management disputes over healthcare benefits. This is, it's almost unimaginable for most people in the United States that other countries do things differently. Mm-hmm. They do, and they get better care to more people for less money.
Mm-hmm. You spoke about the employers choosing your insurance company for you. I have good insurance. My choices are quite limited. And as I said, the limited number of insurance companies that essentially have a near monopoly in many places in the United States mean that your choice is often, even if you were to buy on your own, limited to 1 or 2 plans. But there is, talk a little bit about that myth that we think we can pick our own doctors and insurance companies. That's really not the case, is it?
That's correct. That there's an interesting figure out there that says 80% of people in the United States are very happy with their insurance. Mm. That's a deceptive figure because that's this year. There is so much turnover in insurance coverage, which we don't see in other countries, by the way. About a 20% turnover rate, which means the odds are most people are going to have a different insurance company or no insurance in 5 years. I mean, that's almost a certainty. The average worker in the United States changes insurance 11 times in their career.
And before the ObamaCare mandate to remove pre-existing conditions, which we'll talk about in a little bit of time, that really would lock people into dead-end jobs, and it really would cause a tremendous amount of anxiety if one had to move to a different city or find a different employer. I know just as a physician, I would have patients that would, when I was not in a closed model HMO like I am now, patients who would change insurance companies, and all of a sudden the drug that they were paying $30 a month for under the new plan was costing them $300 a month. And I couldn't keep track of which plan covered which drug for which cost, so I'd be switching statins, switching antidepressants on them, and that basically amounts to poor care.
Yes, it would be common in the United States for someone to have one insurance company 1 year, and then with career changes, have another insurance company the next year, then have COBRA to cover them from that insurance, then go on to the individual market the next year, then after that be uninsured, the year after that be on Medicare. Every one of those is a change in insurance company, it's a change in who your physicians are, who your benefits are, what drugs you have access to, how much you pay for drugs, how much you pay for premiums, how much you pay for deductibles. This puts a great deal of uncertainty into our lives. And when people say, I'm happy with my insurance, that really means, I'm sure glad I have any insurance at all.
Right, exactly.
There are very few people who say, I would rather have my insurance and be uncertain about how long it's going to last, or have to stay exactly where I am for the rest of my working life so I don't lose it, than there are people who would accept, I'd like to know that no matter where I worked, who I worked for, whether I was married or not, how many kids I have, that my family would have access to health care. Right.
And full comprehensive health care, including mental health care, long-term health care, drug coverage, the whole thing.
A good part of our health care discussion really obsesses about cost only, because our costs are so excessive. Well, it's very easy to spend less on health care. Just don't provide care to sick people. Or don't provide care for expensive diseases. Or have deductibles and copays that are so high, sick people just don't seek care.
Right.
Very easy to reduce spending on health care. But the challenge is to reduce spending on health care, as every other nation does, but have improved medical outcomes. That's what the rest of the industrialized world has mastered, and we haven't.
Right, and that, I think, it's antithetical to what I learned about the doctor-patient relationship in medical school, is that you want to basically take care of patients for decades. It does end up providing care. You know the patients well. You're less likely to order repeat or unnecessary tests that another doctor has done elsewhere. You know which, say, antidepressants a patient has not done well with or done better with. And so that switching of physicians constantly generates huge administrative costs, paperwork, getting things shuffled back and forth, electronic medical records which may not match, and as you said, very frustrating for the patients, very scary for the patients, not knowing what's going to happen from year to year.
It's actually even worse than what you've just described, Martin. Not only if I could be living in the same house with the same family, and with a change of jobs, I discovered that I have to change all of my physicians, and my new physicians don't have access to the records of my old physicians because they use different electronic medical records. Also, if we don't have protection from pre-existing conditions, that means I don't want anybody to know about my health care. Because if my new insurance company discovers that I have hypertension from my old records, or coronary artery disease, or asthma, or hepatitis, I'm not insured for that.
Right.
So I would just as soon impede the transfer of vital medical information because it could work against me.
And it's interesting you say that because there are some studies that show that patients keep a significant amount of information back from doctors. Others that show that they neglect to seek care out of fear of just what you're talking about. There's also this concept of rationing through inconvenience, which is basically when an insurance company initially denies a request for a specific medication or a referral to a subspecialist for a procedure. And the hope is that making it so onerous for both the doctor and the patient to jump through so many hoops to get needed care is such that with time they'll either die, the problem will go away, the problem get worse, and they might be bankrupted and then on Medicaid. But insurance companies have a cold, hard calculus that looks at that sort of thing and decided many years ago that creating inefficiencies was actually a way to increase profit, which is not something you see in other industries.
There are numbers associated with that. The insurance companies deny 30% of all first claims. Mm-hmm. That's a lot. And they don't do it because they're bad people. They do it because they're good businessmen. Mm-hmm. As you noted in your introduction, in any industry, the responsibility of any executive is the financial interest of the owners, not the medical interest of the clients. If I'm a CEO of an insurance company and I decide I'm going to put my patient's medical interests first, at the very least, I'll get fired. And at worst, I'll get arrested and charged with felony a violation of my fiduciary responsibility to the owners. Insurance, as an industry, should not be expected to look after the medical interests of its clients. That's not what we use industry for. The 30% denial contrasts with other normal countries, shall we say. As you said, Europe, the Pacific Rim, all the English-speaking countries, where if I'm a physician and I submit a claim for a patient to the insurance company, that insurance company is obligated legally to pay my claim in most countries within 30 days, in some countries within 5 days. Now the insurance company can protest that my claim is fraudulent or inappropriate only after they've paid the claim. Now this puts the administrative burden off the physician and onto the insurance company. Right. Another statistic you have in there, the average primary care physician spends 20% of their time unpaid trying to collect money that's due. This makes the cost of doing business as a physician in the United States much higher than any other place in the world. When you go to a provider in any other industrialized country, you don't go through an office with 3 or 4 people on telephones, going through files, tapping at computer terminals, trying to discover who's going to pay, if anybody, and how much, and for what, under what circumstances, and what papers need to be filled out while you're waiting in the waiting room. You go in, you see the physician, you give them a little card, the physician runs the card through their chip reader, there's your medical record, and at the end, you take your card, you leave, the bill is done. That's an efficient way to deliver health care.
Yeah. And with the declining number of primary care providers, now it's only about mid 30% of doctors in the U.S. being primary care doctors. Having that administrative burden means that they are able to see fewer patients per day, spend less time with their patients, and I think many people are under the impression that they can kind of get in to see their doctor when they want. We actually have fewer primary care visits in this country than in many other countries. For instance, in Japan, they see their primary care docs at least have twice as many doctor visits as we do.
We hear that deductibles and high copays discourage people from making unnecessary visits. There's some people use the food buffet analogy. If all of our care is paid for beforehand, once we get in, we want as much as we can possibly consume. We suck up all the resources, and the system goes broke. As you observe, Martin, in other countries that don't have copays and deductibles like we do, people do consume more health care. They see their physicians 2 to 4 times as frequently as we do. They spend more days per year in the hospital. But they spend half as much and they're healthier than we are. What's going on?
It's true. Yeah, many of the initiatives that are being rolled out at hospitals now are not as much focused on the quality of the care provided as the throughput. How long do the patients spend in the ER? How can we discharge people as early in the day as possible to decrease our length of stay and thus increase our profitability? That's a lot of brain power. That's a lot of administrative work to try to meet certain metrics that often have very little to do with whether or not the treatment you're providing makes that patient's quality of life better.
We do spend an extraordinary amount of money on non-providers tracking what providers do. You know, out of every $5 that we provide to the insurance company, they keep $1. That's before it gets to a physician. Of the $4 that get to us, we spend another $1 trying to collect from the insurance company. So only about 60 to 70% of what we pay an insurance company actually goes to our care. That contrasts with other countries which cut their administrative costs at least by half, and in some cases by 2/3 and 3/4. That frees up a lot of money and a lot of time to provide care for the unmet need we don't get here in the U.S.
So tell me, what are, if you were to lay out the goals that you would want a successful healthcare system to meet, what are those?
First, access when you need it. In every other country, you can get access to care for you and your family when you need it, regardless of what your credit rating is, regardless of what your bank balance is, and typically regardless of who your insurance company is. Access is number one. Number two, we want better outcomes. We don't want to know that if a member of our family gets pregnant, there are 59 other countries where she and her baby have a better chance of surviving the pregnancy. We don't want to lead the world in diabetic foot amputations because lack of care has made a foot ulcer go necrotic. Better outcomes. And we want lower costs. Most people think of costs as an insurance premium, but that's only a small fraction of what we pay. We pay taxes for health care. We pay out-of-pocket payments. We pay premiums. That whole sum has to go down, making premiums go down but taxes go up, or taxes go down and out-of-pocket payments go up, or out-of-pocket payments go down and premiums go up. That's just an expensive game of whack-a-mole. We want access, we want better outcomes, we want lower costs or better care to more people for less money. That's our goal.
And then we could add in things like portability and comprehensiveness of coverage and
I'm not sure I would add those, because if we have a system in which I know any sick member of my family will get care, and I know that the total cost that I'm paying has gone down, and I know the care people are getting is as good as we can get, is comparable to what they get in any other industrialized nation. Things like transparency just matter a whole lot less. I think if we focus on better care to more people for less money, we'll end up with a system that works well for everyone. Here's what I fear about transparency. There's talk about comparing how much procedures cost hospital to hospital in the United States. In my international travels, the only other place that I've seen that posted those costs was in Tanzania in East Africa. The only reason for posting those costs is if I need to know so that I won't go get the care. If it's prepaid, I don't need to know how much it costs. I just need to know the sum total of taxes, premiums, and out-of-pocket payments. So in that sense, transparency is not a virtue.
Well, what I actually said portability and comprehensiveness, but I think with respect to transparency, I think you're right. I think there are areas of transparency that are important, and that if and this relates to medical education and having local opinion leaders, because there is great variability across the country in the number of patients who get, say, PSA testing for prostate cancer screening, and there's a lot of controversy about whether or not that actually improves health and save lives, or outcomes from liver transplants, or simple things like angioplasty for heart attacks. And I think having a single system would, and some transparency over which hospitals and which doctors are doing better would help that. I think we're held back a little bit now by the fact that medical licensing is done on a state-by-state basis, and it's licensing boards are essentially a jobs program for shuffling paperwork, because they don't necessarily ferret out bad doctors. But again, I don't want to make this the main problem. I will let you comment on this. I don't think that's the main problem with healthcare today, or the thing that we need to fix. But I'll let you comment.
Well, you're right. You can die from bad care anywhere in the world.
Right.
The United States is head and shoulders above every other country in letting you die from no care.
Right.
The most expensive patients in the United States, who drive up the cost for everyone, with the worst outcomes, who make our public health and medical outcomes figures the worst in the industrialized world, are the patients who get no care until it's too late.
So what we're going to do, Sam, we're actually finishing up the first hour. This is Dr. Sam Metz from Oregon Physicians for a National Health Program and Mattis Health Doctors. We're talking about the sick healthcare system in the United States and how to fix it, and we've gone a little bit into the problems that have been faced. We'll come back on our next program with Sam and continue this discussion.